Okay.
All right, guys, we are on page 70 in the textbook, 54 in the ringed binder. 70 in the textbook, 54 in the ringed binder. Chapter 8 is on all kinds of documentations of intake and output. Now, the first thing is to keep in mind that we already learned the basics of intake and output. We learned that intake was what the resident did what they drank, okay? It included soup, Jell-O, ice cream, all their liquids, and we learned to calculate that up in the number of ounces, multiply that times 30 to be able to document it in milliliters or cc's. What did we learn was output? For you guys, urine. Okay, for you guys it's just urine. And we learned how to take urine from a bedpan or a urinary hat, transfer it into a cylinder, get it at eye level, and look to see how many cc's or milliliters were in their output. So those are the intake output. Again, I mentioned to you guys on that day that intake for you guys is oral fluids. Those of you that advance, you'll begin to learn that it includes IV fluids. For those that are higher level practitioners, you have to count that in. And on output, it's urine for you guys, but if somebody has diarrhea or vomiting or bleeding, we will calculate that in fluid loss, all right? So, but for you guys, we're making it easy. It is just oral liquids and urine coming out. Now, what we didn't go on in chapter 6 to do was to talk about when there's a misbalance or it's unbalanced. The question on your math practice sheet at the end was, if a resident takes in about 10 ounces and puts out about 10 ounces, are they considered balanced? And again, no critical thinking in this class. The answer is yes. I know they use some. I know that everything that comes in doesn't go out completely because it's utilized. But basically, we are looking to be able to document that this is how much they drank and they urinated adequately. So if they're not doing that, one of two things is going to happen. They're going to develop dehydration, and dehydration is a loss of fluid or inadequate fluid. So it can be from losing it or refusing to take it in. Either way, we can end up in a state of dehydration. For CNAs, the only expectation for you guys, other than the fact that you noted how much they took in and you noted how much they urinated, is to look for physical findings of dehydration. Those physical findings are typically a very dry, parched mouth that may even makes their lips look cracked or chapped. They will have decreased urine output, and what comes out many times is very yellow and very concentrated. They can have skin turgor that loses its elasticity. So I can do something called a tent test, and I can pick up their skin and let go. And if I have good hydration, the elasticity of my skin will take that skin and bounce it right back. But if I'm dehydrated, I lose some of that elasticity, and I can pick it up, and in my elderly, that skin will stay tented on there, and usually we do the back of the hand. If they get in real trouble, we can actually see their eyes appear sunken, and that's a very late finding, but we want to make sure that we're watching for that possibility. They may, if they're cognitively aware, say that they're thirsty. I'm really thirsty, I want something to drink. They will generally be weak from the fluid loss. And again, the expectation of a CNA is to recognize and report. That's it. That's all you're permitted to do. The general rule of thumb is that a resident should urinate once every 8 hours. It's kind of the baseline or the foundation. So if you're leaving an 8-hour shift and your resident has not had one urinary output, in a brief, in a toilet, in the bed, that is considered a reportable event. So make sure that you make the charge nurse aware of that. On the opposite side of that is a word called edema, and they do use this one on the test, and I think it was on your matching yesterday. But edema is where I hold fluid in. Now, edema doesn't necessarily mean that I overhydrated myself and I kept drinking to oblivion. Edema is usually that I either have some sort of kidney disease or heart disease. For that reason, either my pump isn't effective with my heart, or my kidneys are not effective with eliminating. Therefore, I retain fluid and I have edema. And edema is a fancy word for swelling. The swelling or the edema typically starts in the feet and works up. And that's because of gravity, because of dependence, the lower extremities dependency. So when I start seeing puffy or swollen feet, that's a concern. The further it goes up, the more I missed something early on. And so I watch for that swelling. There's a word called pitting edema, and this is where I take my finger and I press down on an area of that swollen ankle, and when I lift my finger, did I leave a divot or a groove? If I did, there is so much fluid in that interstitial space that when I pressed down, I displaced it just enough to feel that pit, okay? And that's called pitting edema. That's bad. Again, we've missed something.
Too much fluid in your body.
Too much fluid. I got way too much fluid in my body.
So that's just with anything, it doesn't like, because I know I was pregnant and my feet swole really bad.
Okay, but that actually goes back to, the fact that, first of all, you had more circulating volume during pregnancy. So your kidneys were being asked to filter more waste and eliminate more fluid. And if your body wasn't acclimated to that, through pregnancy, you'll retain that fluid that your body wasn't accustomed to have. So yes, you can absolutely have that. Yeah. Anna, did you have a question?
Does it do that during your monthly outflow?
Some people will complain of having like swollen fingers or a little bit of swelling during menstruation, and that's more of a hormonal cyclic, but those are minor and they would never be enough typically to put you on a medication to ask you to eliminate. If you look at those agents like a Midol type medication, they do have a little bit of a diuretic in there, but it's, again, that's a very temporary transient thing. So when we're watching for our swelling, we're looking for the swelling or the edema to the extremities. If they are being monitored very critically, heart disease, kidney disease, many times they'll be weighed every day because they'll actually gain weight as a result of retaining fluid. And again, the general rule of thumb is they should not gain more than 2 pounds in a day, again weighing that same time of day, if they're on a strict monitoring of their output. You can see the skin get very tight, it'll get shiny, and if it gets really bad, it will ooze fluid. Has anybody watched the show, My 600-Pound Life? Wow, that's a fascinating show. But on one of the episodes, a lady that was 700 or 800 pounds, they had finally decided that they were gonna let her body eliminate some of the excess fluid by giving her a drug that would force it through the skin more. And they literally had these towels and things on the floor, and you would see fluid dripping from her skin. There was so much excess in that compartment that it was oozing out. But it doesn't take that kind of obesity. Again, if I get swelling, the skin only can go so far. It gets very tight, it gets very shiny, and ultimately I can even see some fluid kind of glisten from within it. With edema, you can also have decreased urine output. So again, now you've got to decide when you're going to report to the nurse, they didn't urinate this 8-hour shift, was it because they didn't have the fluid or was it because they were retaining the fluid? Because that one overlaps to both of the findings that you may want to look for. So monitor those things. Again, your responsibility is only to report that, not to intervene. I think giving you extra pieces of information about what's going on is helpful you understanding the process, but you're not required to know anything further in this class. Okay?
So that's what I was saying. When I was pregnant, they thought I had preeclampsia, so they made me do like intake and outtake.
Yes.
To see if I was putting in enough that I was like taking out, because I was drinking a lot.
Right. And that is literally written in a medical order as I&O. That's the abbreviation. And sometimes the physician will even write strict I&O or daily I&O. And everything that goes in their mouth gets documented in cc's or milliliters, and everything that comes out is documented by cc's and milliliters, because maybe they're going to require a diuretic, which is like a Lasix or water pill, to force the fluid out of their body through their kidneys, through their renal system. Okay? So again, lots of reasons we want to make sure that we eliminate that if it's the case. All right, now, there are specimens, which is the next part of this, that you could be asked to collect other than urine. And one of those specimens is a stool specimen. CNAs are allowed to collect stool specimens. Most of the time we're looking for two things. We're either looking for blood in the stool, or we're looking for ova and parasites those nasty little things. Now, I love the manufacturer of this product. You order these are stool specimen kits. And I love that it's got this short little spoon on it. And I might have to retrieve that stool from the toilet. That doesn't make a whole lot of sense. I would use this obviously if you're retrieving it from a brief. That makes more sense. But you're going to take a component of the stool, you're going to put it in the specimen container cup, seal it, it is a biohazard, and give it to be sent off for the lab. If you are retrieving it from the toilet, I strongly recommend that you get one of those wooden tongue blades that's about 3 times the length of this, and put your glove on and retrieve it with the wooden stick, and then just put it down in the container. I mean, this is kind of crazy for that. And I know, again, on the test, they have asked a question in the past, if your resident needs a stool specimen and they went to the bathroom in the toilet, what should you retrieve it with? But they give answers like a spoon, a fork. They give really stupid answers, but one of the answers is a tongue blade, because it's long enough to reach that without totally contaminating half your arm when you're going to use that one. So, again, you guys are allowed to collect the stool specimen, also known as feces. That's the term, again, if you see that on the test. You're allowed to collect urine specimens. Now, there may be a couple ways that you do urine specimens. It might be that you put the urinary hat in the toilet. You remember that from the other day on Chapter 6. It's that white hat that sits on the bowl. The lid goes down. They sit on the toilet. It captures their urine. I can then transfer it to a collection device. For us that are younger, we're usually sent to the bathroom with a cup. They tell you to clean up a little bit and pee in the cup. You guys can probably hit the cup. We're not going to expect the resident to be able to do that necessarily. You may have a resident who has a catheter in, and so their urine is all going into the catheter bag. And with that in mind, I need to collect the urine from here. So I will take the catheter bag, unclip the clamp, and while using the container or a urinal or some measuring device, I can take the contents of the urine, snap it back, put it back in place, and send that off. The one urine specimen you cannot collect is what's called a sterile urine. And a sterile urine is where I take a syringe, I take an alcohol wipe, I swab this port right here, I take my needle in there, and I aspirate or pull urine from this closest point to the bladder. Because I didn't want it to get in the tubing, down into the bag. I wanted to get as close to sterile as I could. So if they have this and it's a sterile specimen, you're not to collect that, but that's what that's for. And when we break the next time, I'm going to leave all these things up here so you guys can look at them and see them a little bit closer. So you can do urine. On urine specimens, we are usually also looking for blood. And then secondly, bacteria, ketones, protein, things that should not be in the urine that would indicate some sort of urinary tract infection and or some process with the kidneys eliminating. The next specimen that you guys are allowed to collect is a sputum specimen. That's a fancy word for a big old loogie. And so this is a sputum specimen cup. It's going to be sealed, sterile, and you're going to go into the resident's room in the morning, because that's the best time to get it. You're going to ask them to take a couple good deep breaths, and then you want them to hop one in here. Right? And so you'll let them spit in there, and then of course you'll put this on and give it to the charge person. This has been on the test before. I think everybody's at least seen it. This is the biohazard symbol. Because that sputum can be infectious, that symbol will be on it, as it is on almost every container, and that will get sent off. Now we're typically looking for a type of pneumonia, some sort of bacterial growth in the lung, influenza, those types of agents. And again, you guys can do this. What has been asked on the test in the past is when is the best time to collect the specimen? And on the bottom of 71, you will see early morning is the best time to obtain a sputum specimen. The bottom of 71, you want to highlight that. Okay, so you guys can do that. All right, the next one that we're dealing with is laxatives and suppositories. If my patient is constipated, probably the most popular medication on the market is Miralax. Miralax is a powder substance. It is mixed with a fluid, and you mix with any fluid. They drink it, and much like a Metamucil or that type of agent, it is designed to help eliminate or evacuate the bowel. So this is commonly oral. Since this is an over-the-counter medication, technically you can administer it. However, our society has gotten the case of the stupids, and we've decided that the physician can write this as a prescription, even though it's over the counter. If they write it as a prescription, then it can be reimbursed through insurance. It's crazy. I mean, I know that's needed for some populations of people, like parents that have financial challenges and they really do need Tylenol or Motrin for their children, and we do write that as a script. But we've gotten really carried away with that. So because it's probably going to be written as a prescription, it will most likely be given by your med tech or your LPN. A suppository is usually a glycerin suppository. Glycerin is basically like putting a little bullet of Crisco oil up your butt. I mean, it literally looks like a wax bullet and is a lubricant. So the idea is if I put this glycerin in your rectum, it will melt, it'll get slick and slimy, it will stimulate the rectum, and they may be able to evacuate their bowel. That typically only works if the stool is already down far enough in the colon for that to be beneficial. It may not be far enough down in the colon, so you may be asked to assist with an enema. This is the type of enemas that are sold now. This one happens to be a Fleet manufacturer. This one I think is a saline or salt water, I think. Which one is this one? Yeah, this is a saltwater enema. And so with that, when you take this yellow cap off, it will already be lubricated with KY jelly. The appropriate amount will be in here. You'll put the patient in the Sims position. Who remembers Sims from last Thursday? What is it?
Lateral and prone.
Yes, the upper body is more prone on the bedding. The lower body is lateral. So now they're comfortable. I can access the rectal area comfortably. I can leave them laying there, ask them to hold it, hold it, hold it, hold it, hold it, because I want this fluid to get up through the intestinal tract to moisten, soften, and help evacuate the bowel. And they usually are sold as a twin pack because sometimes the first one isn't enough. So this is the most common way that you'll see this manufactured. You know, I used to hate when my parents said, when I was a kid, I'm guilty of it now, when I was in nursing school, this was our enema bag. Is that not crazy? And so we would fill this up, and we would fill it up most of the time with one of two things, milk and molasses or soap suds. That was the two types of enemas that we gave. So we'd put milk and molasses, and we'd put it in here, and we'd warm it up. And we would get the milk and molasses all mixed together. You can understand why we had no way of controlling the temperature on this. It still had the traditional tip that was lubricated. We put it by gravity, we opened the bag, and we filled them up. And we would say, hold it, hold it, hold it. This is a huge amount of volume. We were stupid. I mean, I don't know why it took us so long to realize the bowel really, it doesn't want this much fluid in it. There was incidences of bowel perforations from too much fluid. There was incidence of burns from not being able to control the temperature of the milk and molasses that had to be warm and mixed. So this has gone away. Of course, the manufacturer didn't want to totally lose their investment. So if you find these anymore, typically they don't have the enema component, but they have a nice just plain rubber stopper, and they become a very nice hot water bottle for your belly pain. And then I can just hug the hot water bottle from that. So that's, I know, a lot has
The
changed.
bag is what warms it up?
No, you would actually have to take the milk and molasses and put it in a microwave or heat it, and then you would put it in here, and again, there just wasn't a good mechanism for... They found that combining those two, there was a certain osmotic component, because you're trying to draw fluid into the stool so that it softens and loosens the stool, and they found that that did that. So, yeah. But drink it.
Yeah.
I'm sure I'd crap if I drank that. Yeah, that was pretty nasty. Okay, so enemas, laxatives, and suppositories. You are going to have to find out from the agency that you go to work for what they're going to allow you to do. Okay? Each facility.
In the hospital with newborn babies, put the Vaseline on the Q-tip and stick it.
Okay, a good question. There is, when we get calls for children who have been constipated, I was telling Jake at break that I get so many baby calls, and we are an obsessive parent population that thinks if our kids don't poop every day, they're going to have stool in their brain and they're going to be stupid, or so I don't know what we think, but we get all kind of calls, you know, that kids haven't pooped, and what goes in will come out. Okay, it might be hard, they might have to bear down, but it's going to come out. But one of the things we do teach is to take a thermometer, put some KY jelly on it, insert it in the rectum, and for about 20 seconds, you do a circular stirring kind of motion, trying to gently stretch the rectal opening. It's called rectal stimulation, and if the stool is down low into the rectal cavity, it will come out, and it's such an easy fix for babies. The thing that you have to be sure when you're talking to parents about that, though, is you have to limit that rectal stimulation to 20 seconds or less. Because again, those of you that are a little more advanced in your training and have had some biology and science background, you can create a vagal response, which will drop their heart rate and get them in trouble. So you've got to do just 20 seconds or less, so we're pretty cautious about teaching that anymore. But yes, that's exactly what they're trying to do.
Castor oil.
No, don't use castor oil. No, no more castor oil.
Oh my gosh, that's disgusting.
I know.
Our mama, our stepmama made us drink it for fun.
That's nasty stuff.
Yeah.
All right.
Still drink it to go in labor.
I know, that's true. All right, so castor oil and a bumpy ride in the car, right?
Yeah.
All right, page 73, feeding tubes. Now, there's two types of feeding tubes. There is a nasogastric tube, naso meaning nose, gastro meaning stomach. That was on your matching yesterday. And a nasogastric tube goes in through the nose, down the back of the throat, and lands in the stomach. It's usually used when it's going to be a short-term form of feeding or a short-term means of giving them fluid. It's not usually for long-term use. And if you have a resident with this, your biggest responsibility is to make sure that where it is taped to the face and at the nose, that you're just watching the condition of the skin to make sure that it doesn't break down or get sores associated with that.
Is it that big?
Yes, it is this big around, yes. The other type is a peg tube or feeding tube, gastrostomy tube, lots of words for it, but that's where it's sewn into the abdomen externally. These are more permanent forms of a feeding tube, where for whatever reason, maybe they've had a stroke, they cannot swallow without choking, so they're too much of an aspiration risk. They didn't have an advance directive that said no feeding tube. We stuck a feeding tube in them, and now all of their nutrition comes in liquid form and goes into their feeding tube. You should not be controlling the rate of the feeding tube because that's set at a rate to not rupture the stomach. The main thing again that you should be doing is reporting if it doesn't look like the pump is functional or if the area around the skin looks red or inflamed or it doesn't look right to you. But again, that becomes your responsibility as a CNA.
What about a person with a trach?
Trache's different. We'll do trachs another day.
Is that what a PICC line is?
No, a PICC line goes directly into an artery, and it's like for antibiotics, people will go home, or people on chemotherapy, and they'll put it in the subclavian, they'll put it up here. Yeah, that's different. All right, oxygen tubing is the next one. There's several types of oxygen tubing. The most common that you guys will see is called a nasocannula. Naso meaning nose, cannula. It will have two little prongs in it. It will be inserted into the nose. These go over the ears, and then I can cinch this up under the neck to make sure that it's snug. These are typically those individuals that are on continuous oxygen therapy, like my emphysema patient and congestive failure patient. So it is a low concentration of oxygen, usually 4 to 6 liters, giving them about 40–50%. So they cannot be in acute distress and be on this. Right? They start getting in trouble and they're struggling to get their breath, their color's not looking good, we're getting in a bind, then we're going to switch from a nasal cannula typically to what's called a non-rebreather mask. It's like when you're flying. And now I can crank this bad boy up to about 12 to 15 liters. It'll inflate this bag. And now when I have this on my resident, I'm giving them about 80 to 90% oxygen. So, but if I'm on this, they need to be shipped out of your facility. This means I was in trouble, I'm requiring high concentrations of oxygen, something's going wrong, I need to be getting out of there. So again, not your responsibility, but when we learn vital signs on Friday and Monday, we talk about what to look for on respiratory distress. Again, when you recognize that and tell the nurse, and the nurse comes in there and slaps one of these on, I hope to goodness she knows that she needs to be calling EMS and transporting that individual to the hospital, because that's way beyond what should be administered out of hospital setting, unless they're in the ambulance. There is an in-between one, which is just a simple mask. You won't see this commonly. This is a baby one. It's kind of in between, usually 6 to 10 liters, usually about 60–70%. We pretty much don't see this anymore. You either need a little or you're in trouble and you need a lot. But again, just so you know, that is available. Oxygen is a medicine. Oxygen has to have a doctor's order. It has to be ordered in a specific amount of liter flow. That means you cannot go in there and decide they look like they're struggling a little bit and crank them up from 2 liters to 3 liters. It has to be a doctor's order. You can tell the nurse you're concerned, but she will even call the doctor and say, this is the oxygen saturation, we're concerned, can we increase the oxygen, and that'll be done. Again, your responsibility is when you are in the room with the patient, is it on? Or did it slide off and the prongs are in the ears? So you can readjust it on the face, you can check the site where the tubing rubs the skin, you can ensure that there is flow of the oxygen, but you cannot adjust the settings, turn it off, take it off. I mentioned to you on day 1 that these facilities can't stand having patients on oxygen in their facilities because they don't have oxygen in their wall delivery system. So they typically have to have a unit like this. And so here's my oxygen delivery system, and most of these are only geared to go to 5 or 6 liters. So you can't, crank them up to be in big trouble. And then in addition, they have to have a humidification bottle on them to keep the air moist, because if I just pump air in your nostrils, you're going to have nosebleeds. And so now I have this huge unit. I usually have 10 to 20 feet of tubing. It's a huge risk, fall, all the things you got to check, the tubing, the oxygen, the liter flow. So they can't refuse you, but they don't like it at all.
When you move your patient, do you have to have somebody with you to move that?
You should, yes. Yeah, absolutely. Don't try to move all that on your own.
Will we come in contact with any patients, like when we get there in the morning, that has sleep apnea and you have to take them off the machine?
CPAP machines, I've not seen anybody on CPAP in the nursing home. I think, again, the idea is if they have sleep apnea, then they have sleep apnea. If they pass during the night, then they pass during the night.
Oh, God.
I know. All right, catheters are our next tube, catheter tubes. You will hear the term Foley catheter. That's really an unfair term. Foley was the first manufacturer of a catheter, and so in healthcare we just got used to calling it a Foley catheter. So these are catheters. These go into the urethra of a male or a female. The design is for the catheter to go into the bladder. There is a port on the tubing. On that port, once it's in, we're going to inflate salt water, saline or sterile water. And then as I gently tug back on this catheter, this balloon is now blocking the opening between the bladder and the urethra. Then you'll see there are these tiny little islets of Langerhans, you don't have to know that. Sounds fancy. And the urine will come through those islets, drain in by gravity to the Foley catheter bag, and that's how the mechanism works.
Are we going to have to insert catheters?
No, you will not be allowed to insert catheters. Again, I think that in home care settings, the home care could choose to train you and check you off and do that, but for the most part you do not. It's a sterile procedure, huge risk of infection, so we usually do not. Now, with women, the catheter goes in. Their biggest risk is, if you think about the anatomy of the women, we have urine, vaginal secretions, moisture, it's warm, it's dark down there. I'm going to get that bacteria on the shaft of this catheter. It potentially can track back up through the catheter and give them a urinary tract infection. Women have a high risk of urinary tract infections with a catheter. With men, it's different, because if you think anatomically, once this catheter is in, the exposed portion is right at the end of the penis. There's not going to be the secretions and the discharge. They even don't have as much risk as sitting in stool and having that point of entry be in their brief in stool, like women who can. So they're at a lower risk of urinary tract infections, but they also have a harder time getting these in. Because gentlemen, our elderly gentlemen, usually end up with an enlarged prostate. And so as you try to advance the catheter, the nursing staff, you meet resistance. You're going, dang, I can't get that through there, because the prostate has swollen, enlarged, and is compressing on the urethra, and so I can't get it past. So they'll probably call a urologist, and the urologist will come and put a wire through this bad boy and make it stiff, and they'll kind of force it through and get it to the bladder. If they can't, then what they're going to do is they're going to choose to do a condom catheter. I wish I knew why, but condom catheters are called Texas catheters. I think that's kind of mean because everything's bigger in Texas, but I have no idea, but I'm not kidding you. This is what they're called, Texas catheters. Go figure. And so on a Texas catheter, when you take it out, it looks just like a condom. It's going to be rolled like a condom. This will be slid onto the shaft of the penis for the resident. This end is universally adapted to the size of the catheter tubing. So I'm going to attach that there. Then I'm going to have a piece of adhesive. Be nice to our gentlemen. And when you put the adhesive on, try to not get a bunch of hair caught in that, because that's just not nice when I have to peel it off. And I'm going to take and anchor this onto the shaft of the penis. I know. Now, here's the challenge with this. And again, I don't mean to embarrass people, and we've got a lot of diverse age groups in here. But understand, you are typically putting this on a non-erect penis. Okay, so the idea of it sliding down, like you would naturally think it could, is not the same. So you do tend to have to kind of pull or retract and do your best to get it slid down as far as you can before you anchor it, so that again, we have the best chance that it's not going to leak and that we can obtain the urine into here. It obviously is much more comfortable for the male not to have that tubing in. It's, they usually have it changed every day, and so infectious issues are not there. So this actually becomes the form of choice for a lot of our home care residents, our males, and some of those in the nursing home, but it's called a condom or Texas catheter. And I didn't show this to you guys a minute ago, but all of these catheter sizes, no matter which size, they're all going to universally adapt to the catheter bag to do that. Now, one of the questions that's been on the test before with the catheter bag is, I am taking my resident to activities and they have a catheter. Where should I put the catheter bag while they're in the wheelchair? And the answers were IV pole. You think? No. On the wheel? No. On the handle? No. At or below the level of the bladder. This is purely gravity. This is not suction. And so I have to ensure that urine's going to go down and out, not back in. Okay, so everything's gravity. Again, when you're in a resident's room, that's why you'll see this hanging on the side of the bed frame. Not on the rail, but all the way at the frame, so that I'm slightly below the level of bladder.
I don't know if this makes sense, but with the Texas catheter, what would be the point of it? Because, I mean, it's not going into the bladder, so wouldn't that just be like them being able to go by themselves?
Okay, so are you talking about from the standpoint of where this hangs, or why having it?
Why having it?
Okay.
Because it's not inserted into the bladder?
Right. The residents and the clients we have right now in home care that choose to have this don't want to sit in a wet brief.
Okay.
And they would rather have this put on, many of them at bedtime, put a brief on, and then they wake up dry and clean with no skin breakdown. We have one client that doesn't use it during the day. He wants to go to the restroom, but he doesn't want to be awakened during the night. And so he chooses to wear it at night to not be soiling on himself, and then we take it off in the morning and do good hygiene, and then he puts it back on at night. So the advantage really is so they don't sit in moisture,
So it's just like a personal preference
In most
rather than a
instances,
medical
right,
thing?
that's correct. Oh, yeah, exactly. Again, unless we're monitoring urinary output and we can't get a regular catheter in, that might be another reason to use it. But our home care clients actually choose to use this because they just don't want to have all that urine up against their skin, particularly at nighttime or bedtime. All right, your responsibility with catheters is, again, make sure they don't get pulled out. Most of these will have a piece of tape where it'll be taped to the thigh just to keep from pulling. If you can imagine that balloon on the end and suddenly it gets jerked out, that balloon will rip the urethra, okay? So we gotta be very, very careful. And more for women than men, you guys are gonna learn a skill called catheter care. It's gonna be one of your potential skills you draw. And it's going to teach you the technique for cleaning the external portion, the exposed portion of the catheter, to reduce the risk of these women getting a urinary tract infection, as all of that is tracking back up through the catheter. And again, as I mentioned, I'm going to leave all this out for you at break so you guys can look at the different types of tubes. All right, the next type of tube that's listed is a rectal tube. That is not commonly used anymore. A rectal tube was designed years ago because if somebody had a lot of gas, also known as flatulence, and they were not able to pass the gas, we needed to be able to insert a tube into their rectum to provide, take pressure off the sphincter so the air would come out the rectal tube. And so they would insert these in to pass the air. They've now found, and again, it's amazing how easy medicine gets sometimes, that you can reposition people and help them eliminate gas just from repositioning. And the best position acutely to eliminate the air is to put them on their belly with 1 or 2 pillows underneath this section. So they're like a dome laying on prone. And just that will typically kind of stretch out and displace the intestinal tract. And you'd be surprised how much they can get out through that. So know that they exist, but you probably will not see them anymore. A colostomy or ileostomy. First of all, the word ostomy means that we have to have a surgical procedure in order to eliminate waste from the body. The most common ostomy is a colostomy, meaning colon, and so it's to eliminate stool. So let's say that the individual had cancer, and they went in for surgery, and there was such a large segment of their bowel that had to be removed that they could not reattach the ends and know that stool was going to be able to continue down that port to their rectum. They will then take the end of the intestinal tract and they will bring it out the abdomen, and they will stool out their abdomen. Right? Now, it is usually very high up on the intestinal tract, so don't think that what's trying to come in this bag is formed stool like you put in the toilet. This is a liquidy, pasty substance because it's so high up. The bags will come with this adhesive on the back, and everybody's opening could be a little different size, so these will be cut or adjusted to the right size. This is a very safe form of an adhesive. We will apply that to the opening, where now the stool will come into the bag. The bags will have a clip or a clamp on the bottom of this, and they'll stool into the bag. And so what your responsibility is to do is, when they have stooled, I'm going to empty the contents. And again, you can empty it into a urinal or a container and get rid of it. One of the questions that has been on the state exam before is, how often do I empty a colostomy bag? And the choices they give you are once a shift, once a day, once a week, and then the right answer, any time you see stool. Okay? Think about the idea is that you don't go to the bathroom all day and wait to flush your poop at the end of the day, okay? Or at the end of the couple days or a week. You flush it every time you go to the bathroom. So if I look and I see it, I'm going to empty it. Doesn't have to be half full, doesn't have to be a third full. If I see stool, I want to empty it. Most of these bags stay on for several days. Because again, if you can imagine that this is what I'm doing constantly with this bag, peeling it off the skin, that skin is going to get so irritated. Stool is typically acidic. It gets on the skin breaks down. So most of the time these are on for several days before they're removed. You young people who have decided that you know how to pierce and barb everything probably did one good thing for medicine, is that we learned actually that we could put these little magnetic barbs underneath their skin, and they now have one that kind of clamps and snaps on. So that was one good thing out of all y'all's body piercing that we learned. So you may see that. Yours is just your ears. Yes, Valerie.
I was gonna say, like you said, they keep it on for days, but you're not supposed to. Right?
Yeah. Because again, if you take this off every shift or every day, it's like having tape on your skin from an IV.
So you're supposed to just empty it.
Empty it, correct. Empty it. Put the clamp back on. Yeah, put the clamp back on. You empty it. A lot of them have carbon fibers or carbon lining in it for odor, absorbing odor. Yeah.
Aren't they supposed to only have it on for 3 days? My sister-in-law's got one.
Yeah, it depends on what the doctor orders, but again, it's never a shift or a daily thing. It's several days at least, because again, you're not gonna do them any good to keep pulling this on and off.
You can't
It
clean it.
smells like death turned over.
Oh my God, it
You
stinks.
hear me?
It does, but you'd be surprised how many people in our society are working a full-time normal career wearing this and you don't know it. There's a paramedic for MedShore that I've known for years, and he has a colostomy, and you would never know it. He has the carbon-lined bags, they absorb the odor. Now, the one thing you have to think about is, guess what? You can fart through your colostomy just like you can through your rectum, okay? So if you look at the bag and it's puffing up, they've got air in the bag. And so I gotta get that out too, so keep that in mind. It's very odorous, but there are ways to keep it clamped and clean and prevent that. Mallory?
I was gonna say, if you have like a weak stomach, what are you gonna do about that? Like,
You're gonna puke in the
smell?
toilet and keep on going.
The
No. Weak stomachs are tough in medicine, there's no doubt. My suggestion is breathe through your mouth, and you're just gonna have to trust me, you won't taste it, okay? Breathe.
Can you wear a mask?
No, you really don't want to for odors, because that's offensive to the, I mean, you're
No.
telling that resident you stink.
I mean, not like that. I mean, just like, I guess, I don't know, put a mask.
Just talk to them.
Yeah, keep your mind off it, breathe through your mouth, and the first day, if those of you guys are really worried about the sensitivity, just get some Vicks Vapor Rub, and just put it underneath your nose. Just put a streak of it underneath it so you get assimilated to that, okay? My daughter that's graduating from PA school next month, I made her take this course, okay? She was gonna be animal medicine, and I knew she was not gonna be animal medicine. I knew she was gonna be people medicine, but I couldn't convince her. She was already in college. No, I guess she was a senior in high school. And I made her take this class, and the first day she went to clinicals, she puked in the trash can. And she came home and said, I can't do this, I couldn't stand it, I pooping. And I said, I need you to do this, because one day you may be taking care of me. And the second day, she came home and said, okay, it was a little bit better. And the third day, she came home and said, I made it, didn't even bother me. And you know, at the end of the clinical rotation, she said, you know what, I want to do people medicine, I don't want to do animal medicine. And now she's going to be a PA in 4 weeks. So she started off puking in the trash can. So don't be embarrassed by that, okay? Every clinical, usually somebody's going to puke.
Okay, well,
And
that will be me.
That's okay, that's okay. Just grab the cash can, puke. If you're getting hot, and you think you're gonna pass out, just step out discreetly. The preceptor's not gonna grab you and say, get in here, okay? Get used to it. Just don't feel like you should be in there and be perfectly capable of handling this the first day. You won't. Most people aren't.
Wouldn't puking be more offensive though than the mask?
But I think you have to say to them, I'm so sorry, I just wasn't accustomed to this, I didn't mean to embarrass you. But the mask, if you start getting used to it, you'll never get assimilated to the smells. And then you're gonna wear the mask for every time you change a brief, and every time somebody vomits, and every
I
time.
want to do it all day.
No, I'm not gonna let you do that.
Just have it go for a couple days.
All right, colostomy, let's see, waste, eliminating, care, around it, bandage, taking it out, emptying it. What do I need to tell you about this?
How would you clean it? Like,
You don't, you dispose of, these are disposable.
but I'm saying like when you dump the stuff out.
You don't.
You
You
just
dump
dump it out.
You dump, and you reclamp. Is there some stool stuck to the lining of it? Yes.
I'm told to put water in it and mush it around and empty it. No?
I would not. Because the problem is, if I'm putting water in it, I've got to go this direction, right? And I'm actually then trying to clean it, some of it can go back in there. And what am I using? Am I using tap water or am I using sterile water, you know? So you really should not be doing that.
Another reason not to know.
Yeah, absolutely, absolutely.
Is it just like if they were to use the bathroom that like out of their butt?
Yes, except it's soft, like toothpaste or pea soup or mushy diarrhea. It is
Why
not
is it a different texture?
because, y'all listen up, she's got a good question. She wants to know, why is it a different texture coming out here versus the rectum? By the time your stool goes all the way through your intestinal tract, it is losing fluid and becoming more formed. So by the time it's in the rectal cavity, there's much less fluid in than right when it comes out of your stomach going into the intestinal tract. Okay, because it's sure not formed in your stomach, it's digested and broken down and then begins to come through. So depending on where it is, depends on the consistency, but it's never so far down that you will see formed stool. Because you also have to think that when you have formed stool, most of us do a little bit of bearing down when you have a bowel movement, right? I mean, a little bit, I mean, sometimes more than others, but you don't typically sit and just let it roll,
Can
you know, when
they
it's
feel it?
formed.
Can they feel it?
No, they usually don't feel it.
Your mom.
He's my mom, okay. We're good.
Yeah.
When you go, how do you, like, when you go, like, if you have a virus or something?
If you what?
Like a virus and then it's real
Oh,
like that?
Good
like
question.
how-
If you have a stomach virus and you're gonna have diarrhea or vomiting, you're gonna have diarrhea out your bag and you're still gonna puke out your mouth. Same thing.
But I mean, like, how come it's like runny and not formed then? Like,
Because of the fact that the body's trying to rid itself of the bug, and when the bug gets in the stomach, we're trying to get it out first. That's why vomiting usually comes first. And then it's just blowing out the lining of it doesn't have time. It's running through the system so fast it doesn't travel the same to get out. Good questions. Yes.
Isn't there two forms of those bags?
Well, they're bags or holes.
No, the bags. I know there's
Well,
one-
there's different kinds now that snap on. I mean, there's different,
They look like
yeah,
a set.
manufacturers,
I know
yeah.
there's one like that, and then there's ones that there's two, and you have to place them together.
Oh, I don't know. I haven't
There's
seen that.
single, and there's,
Oh, I haven't seen those. I haven't seen those. But Google, right? We can Google and find them. All right, let me tell you guys two other things real quick, and then we'll wrap up this chapter, and I'll quickly introduce you to my mother and let you see her exorcist arm. All right, the last two things in this chapter are dressings and beds. You all typically will not be doing dressings, wound dressing, those types of things. That is a wound nurse responsibility. However, if you go in to change a brief, and they have soiled their brief, and they had a dressing on the backside, and now it has urine or stool on it, you should remove it to get it away from the skin. It's biohazard, gloves, biohazard bag, and then let the wound nurse know, I needed to remove that dressing, it was soiled with urine or stool or whatever. That's really the extent of what you guys are supposed to do with bandages. Again, in home care, those agencies have the right to train you in certain skills, and that may be different, but for the most part, you are not. Just keep in mind that dressings that are covering wounds are infectious. We're just gonna assume that anything's a dressing, whether it looks dry, bloody, wet, purulent, it doesn't matter, it's infectious, and I'm gonna handle it that way. The last couple paragraphs is on bed making. The state decided a couple years ago to remove occupied bed making as a skill for CNAs. The reason they decided to remove it was that CNA's training is geared towards long-term care. And in long-term care, there is no excuse for a resident being in the bed 24 hours a day, 7 days a week. That's the rationale. So every resident could at least be sitting at a bedside chair or Jerry chair while you change their bed. Now, I would argue at 2 in the morning though, when they've soiled their sheets, you know, getting them out of the bed to me is a little bit mean. And I wish that they had thought about that when they did that, because I don't want to get them up every time I have to change sheets, but just so you know the rationale, it was because beds should not be occupied all the time. Now, if you guys go to work in a setting, a hospital setting, a hospice setting, then you will want to know how to do an occupied bed. I do have a video that we can look at. We won't look at it right now, but to show you. But the biggest thing that has been asked on the state exam before about the bed is that in order to prevent drop foot or contractures of the toe, a CNA should A, make the top sheet as tight as possible, B, make the top sheet as loose as possible, C, create a toe pleat in the top sheet, and D, something else. Toe pleat is listed for you on page 77, first column about midway down. And what you're doing after you make the bed, you're just going to the bottom 6 or 10 inches, and you're just picking it up to make like a little tent, and then just letting go, and it creates enough looseness at the bottom of the top sheet so that their feet can move, and we don't have it so tight, their feet are in there flat down, and I developed some problems with that. All right, let me stop this for a minute. You guys look